Gupta to come on stage and deliver their presentation.
Always my pleasure to be here in ICCCON and respected chairpersons. So I will try to present a case which was done actually in France, but it was the first case from India. That was November 2011 when TAVI was not available to us. It's not some difference because I made another slide presentation, but it is the older one. Doesn't matter. So I'll also do a small 3 minutes to introduce because I worked with Alain Cribier in France in 96 to 98. The first few slides will be actually talking about the transcript, how it has actually come. The first in man, a vision by pioneering team, Rouen, Alain Cribier with Rouen University Hospital, and they did the first case in 2002, April 16, and we recently celebrated. And actually, I was working with him, so I have few slides to show because this is the cath lab of Rouen 1996, my Dr. Krieger and the other team members, my family there. So I always feel good to show this. Dr. Krieger came to my house in Delhi, and we had a good time about 4 years back. My son with the cycle. So this was a good stay with me. And at that time, Dr. Krieger was actually thinking about, I still remember vividly, I was in the Guinness car. He said, I have a project of developing something non-surgically. You can replace the valve, put another valve, aortic, so something which went off my mind. I could not understand what he was talking. So that was the time when he was contemplating then of course there were a lot of problems we faced in finding the company. The same company, Edwards, had completely refused to undertake this project, saying that this is the most stupid project at that time. And the same company finally bought the whole system, and now they were selling like anything. Edwards valve. So the plan of presentation will be a little about AT, aortic valve stenosis. 26% of the population age of 65 and mild to moderate severe stenosis. Standard risk patient mortality after AVR is low, but in high risk patient it was found to be high. But at the same time, we always know that after successful valve replacement, patient lifespan returns to normal as compared to normal to that of general population. So the first, of course, the step for the development of the valve was 1985 when he did the first aortic valvoplasty, and that was actually one of the most enthusiastic things, which was watched completely by even Americans, and they came and they did understood how he was able to do aortic valvoplasty at that time. In a 72-year-old, highly symptomatic and with a syncope, 2 years later, patient was okay. But of course, we know that aortic valvoplasty has a limited life, and there was a recurrence in these stenosis. And BAV now is required only for the purpose of rapid ventricular pacing. At the time of rapid ventricular pacing, with rapid ventricular pacing, we have to open the valve so that we can put the stent. So development of this, I want to give another 1 minute because it was found to be very highly challenging. Why? Because the valvular calcification surrounding structures like coronary arteries, mitral valve, IV septum, and major clinical issue was to avoid a coronary occlusion, mitral valve injury, permanent AV block, stroke, aortic regurgitation processes, migration, non-lasting result. These were the actually challenges which was being thought at that time. And the goal was to improve the results of BAV that should not be any stenosis. And it was actually a hypothesis of implanting a valve prosthesis with a diseased calcific aortic valve on a beating heart using percutaneous catheter-based technique. This was almost unrealistic project considered to be at that time when I was working with him. But of course, what actually was the good point, a challenging combination of balloon expandable frame and valve structure should be required. And a balloon expandable stent with a high radial force might keep the valve open, and valvular structure would have to be attached within a stent. This was the hypothesis. A valvular structure has to be attached to the stent, which will stay there because of calcium. And we all know that it has been now April 16 to the first case was done with Martin Leon working also from that time from the US, because that was at that time they had made a company which Martin Leon and Helen Cribier were working along with Israeli people. So The first case we all know was done very successfully in April, and now 20 years of celebration was done in 2022 in May last year in the Euro PCR time, and I think most of us were also, I was there, of course, with it. So I would not talk about the clinical case report. I have only 3 minutes to go. So it was an 83-year-old Indian male who was treated with transcatheter aortic valve of severe symptomatic aortic stenosis in Rouen, France, and it was actually referred by our colleague from surgeon from Delhi, Apollo Hospital, and this patient actually was having, of course, requirement for the TAVI, severe aortic stenosis valve area 0.7, peak greater than 85, mean greater than 65, ejection fraction normally maintained. Post bypass patient, long-standing diabetes, graft patency was okay, except for one surface vein graft, which was occluded. Of course, comorbid factors were poor lung function. Surgeon actually had refused because he was actually, first of all, VVIP, and secondly, he had a severe lung function COPD, and he was requiring BiPAP every day. Nephropathy was also there. So this was considered to be almost non-surgical at that time, and he received aortic valve. So decision was taken to do TAVI. Pre-procedure evaluation was done in our hospital in Apollo. Aortic radius of 23 millimeter and CT was not performed here. We did MRI and then we did it. The patient was successfully treated by TAVI in Rouen, France, with deployment of Edward XT valve at that time, not Edward Sapien. So 18 French femoral sheet was used, of course, Novafresh sheet, conscious sedation, IV Mediogram. In this procedure, I was there, the scrub with Dr. Period, of course, we did together, was actually only 40 minutes procedure by watch at that time, even November 2011. Prostate technique for femoral artery closure procedure time was only 40-45 minutes. Few angio clips which will be not very useful, but still I will show you some cases. Yes, this is a aortic right angio detail from the control network side with TAVI procedures. 18 French sheet was used at that time, and uh, 18. This is how this was. You can see the aorta was having calcium, and of course many places of aneurysm. Implants were crossing the aortic valve. The pigtail aortic valve crossed. The purpose of telling about this patient was that at that time, when TAVI was actually not available, we could do that. And you can see the positioning of the valve, Edward external position. It is going up actually, not going up slowly and without any major resistance. Now it is crossing the uh, arch of aorta, and now finally it is being deployed in the exact, in the precise position. This is how the valve is being positioned, and final shot. Of course, at the same time, they were doing the aortic root angiogram to see the positioning, and then this is deployment. So the post-procedure aortic gradient. This is again I would like to show this one, and actually the precision positioning was done with the aortic root angiogram at the same time. You can see. No, sorry. Okay, so post-procedure gradient reduced immediately from 18 meter of peak, and then aortic root angiography revealed mild aortic leak at that time. But it actually, it was grade 1, and then actually over 2 days it improved normally. No fresh removed and angio to see the ilex, and then final angiogram to see the groin. Everything was fine. Then post-star technique to seal this. This is after removal of the post-star and the patient fluoro. You can see the valve deployed. The procedure time, the patient had high creatinine little, but it was actually came down within 5 days of procedure. Patient would start third day, and of course it was conscious sedation. And this is the older slide. So in 8 years, patient survived completely. He recently died because of his other illness, especially kidney failure. The conclusion was TAVI could be easily performed in relatively high risk, to the high risk patient with minimalist environment without utilization of transesophageal echo, without anesthesia, with conscious sedation and the procedure time of this. Perhaps it was actually the first patient who was treated, not in India, but of course at that time TAVI was not available because TCGI regulation was not there at that time. So thank you very much. And this was a medical breakthrough. Last slide I would always like to present, which of course this was the TAVI 20 years celebration. This was last year. So within 10 years, TAVI had become further and then more improvement and more number of cases being done. Thank you very much for this.
Thank you, sir. Very interesting case. Yeah. Any questions from the audience? Thank you. Call the next presenter. Okay, Dr. Dilji Shetty is the next presenter. And he will be presenting TAVI pop-up.